Okay. Great. Looks like we have the CEPAC all back, and we're getting the folks up at the front table. The folks are here to help contribute to the discussion that we are going to continue to have around the evidence as we move into the voting phase. So let's get started again. This phase is a period when we will have a lot more discussion about some of the issues that have already come up today, and we will obviously move through that to some specific voting questions. I'm going to first introduce some of the format of the voting questions and make sure that the CEPAC is logged on to the system. Actually, Sonia, let me let you do this part.
We always do a test question to start out. Phone question. I want to make sure that.
Oh, I'm sorry.
Speak into Steve's time. So I want to make sure that everybody is logged in. And I might I'm just going to walk around and.
Sure.
I know. Good.
These are hard questions. We submit, so we click.
Oh, all right. I get to do the fun part then here. All right, so we have a test question just to ensure that the voting system is up and operational. So, which of these statements about Kansas City? How about Kansas City? So this Kansas City is false. Kansas City has more barbecue restaurants per capita than any other U.S. city. ICER's president, Steve Pearson, was born in Kansas City. Kansas City was the first city to implement prohibition, or Walt Disney opened his first animation studio in Kansas City. 3 of these are true, 1 is false.
Oh, which one? Hold on.
All right. We already have 12 responses, so let's see the results. Okay. Actually, I don't know which of these statements is false, but it's not that I was born here. I was born here. So, but what's the false?
The false statement is C. Kansas City, in fact, ignored prohibition. That's my
Ergo, its long-standing reputation, and why I was probably born here. You never know. All right. So we know we have 12 voting members of the CEPAC. That will be the sum, and we'll wait for the votes to be placed. As I start to bring up the voting questions, some of you will feel compelled to vote early. I'd like to ask you to try to wait until the discussion has been completed, because it's always possible that discussion will influence your thinking. So I understand that sometimes people will jump in, but let's, in general, try to wait until the discussion's completed. So the first voting question is, for patients with RPE 65-mediated inherited retinal disease, is the evidence adequate to demonstrate that the net health benefit of treatment with Voretigene Neparvovec is greater than that of supportive care? Yes or no? Now, you guys know in your materials you have that evidence summary of tables from the overall report that you can reflect on. I'm not going to point to use the specific pages that might be relevant to this, but I'm sure the first few. Does the CEPAC have any questions or discussion around this question of adequacy of the evidence that treatment is better, if you will, provides a better net health benefit than supportive care? Yes, Reem.
I think one important distinction here is that the comparator. The comparators do nothing and wait for them to go through the natural progression of the disease, which is not so clear, but what is clear is the natural progression eventually will lead to loss of vision. So,
given the benefits that were shown in that graph and in the other data in terms of the ability to navigate with lower levels of light, I could imagine that any further thought about this might dwell upon the risk of harms that are unknown or known but not, kind of factored in. So I don't know if anybody has any questions or comments about the harms. Yes?
Maybe Dr. Kay could address the surgical complications. It seems fairly complex, and how many retinal specialists really are competent and comfortable doing this kind of surgery?
Sure. The vitrectomy portion, 100% of retina specialists, vitreoretinal surgeons would have extensive training in that, and probably 100% of vitreoretinal surgeons would have done subretinal injections in their training or in their clinical practice. We do, apart from gene therapy, we do a subretinal injection for a disease called age-related macular degeneration if a patient has a large macular bleed, and we inject a substance called TPA or Alteplase. So this is a relatively commonly done. I'll do maybe 3 of these cases or 4 a year, not 3 or 4 cases a day, where I'll do a subretinal injection outside of gene therapy. So, and I would say most of my partners are also well-versed in doing those subretinal injections. The difference is just the specifics of doing a subretinal injection for a gene therapy trial. Having done a subretinal injection for a gene therapy trial, different sponsor, different disease, different patient population. I can tell you that there are some, and actually give talks on this at Academy of Ophthalmology and ASRS every year, just on the logistics and the considerations of how to do a subretinal injection when you're doing it for a gene therapy delivery. And so there's instrumentation specifics. These are nothing novel or groundbreaking, but it's just things that should be standardized. And that's why I think the Spark is doing this Centers of Excellence standardization, training. Not so much that we have to train a surgeon how to do a subretinal injection, because they should know how to do that, but how to, specifically, do you want to make your retinotomy is the site where you perforate the retina, make a small little hole. Where do you want that to be? Do we want it along the supratemporal arcade? Which direction do you want to be pushing the vector? Exactly how much volume are we going to deliver? Fluid dynamics, do you want to have a 4th cannula in to allow egress of fluid? So there's little surgical things that could go on and on, but there are a lot of little tiny things that can make a difference of how that bleb is going to be delivered. So nothing novel or groundbreaking, but just things that, even a surgeon could talk to another surgeon for 10 minutes and have a good idea of how to make that standard in between cases. The risks are really low. I mean, if you look at the data, and I would agree with this from my own experience, it's just the risk of a vitrectomy, small risk of retinal tear, small risk of cataracts, small risk of things that we would have with any ocular or retinal surgery that are quite small, and the patients tolerated the surgeries very well.
All right, thank you. Paul? No, I'm sorry. Not during this phase of the meeting. Yes.
No, I thought in the phase 1 trials there were 2 people who had a quick loss of sight that seemed to be harmed by the injections. So I guess the question, what percent would we say were harmed? What fraction do you think are harmed?
Yes, so with any surgery, there can be a risk of endophthalmitis. So when I'm doing a surgery on a patient, for any reason, I say there are risks. I'm a conservative surgeon. I'm going to go through an informed consent process. So I believe that one of the patients in that had endophthalmitis, which is about a 1 out of 2,000 or 3,000 risk if you look at the literature going into a vitrectomy surgery, or probably less. So that's something that we have occur with any vitrectomy surgery, and those patients are almost invariably going to have some element of vision loss because they've had an infection develop. And that's really nothing to do with the product or the vector or even the fact that it was gene therapy, just because we entered an eye, maybe it's something with the lack of betadine or fluoride in the patient's lid margin. So just either a patient issue or something in the surgical environment that particular day, and kind of an unlucky 1 out of 2,000 infection risk. The other patient, I think that there was OCT macular thinning. We could go at length into whether or not we should or should not inject and detach the fovea, which is a whole other discussion, but I don't know the details on exactly where the blood was in that patient, but that patient did have some thinning of their OCT, as far as I recall, and I could be incorrect here, and it suffered, and I don't know what the amount was, of visual acuity decline. But I think, overall, those were low numbers, and looking at the 34-something plus patients in the phase 1, 2, and 3 trials, overall patients had a significant benefit and the safety issues were low.
Right, but you could say it was 2 out of 34. Is that so based on that data, right? Someone double check me on that number, but I know it was 2 patients. I'm not sure of the total number in the phase 1, 2, and 3 trials.
That I'd be willing to take a statement from the manufacturer, the number of total patients treated. The denominator, if the numerator of patients with total vision loss was 2, what's the denominator of patients? 41 patients.
41, so correction on my part. So sorry about that.
Thank you. Okay, I'm going to move on to a vote on this question. I think people have already opted to vote, many people. But let's go ahead and complete the voting. Is the evidence adequate to demonstrate the net health benefit is superior with treatment with Voretigene than of supportive care? 12 yes, 0 no. All right? So, the next set of questions are that part of the value framework where we want to talk about other potential benefits that might lie outside of the data in the clinical trials or the cost-effectiveness modeling. So let me just read through these, and then we'll have a rich discussion that I hope will involve multiple members of the group up at the front table. When compared to best supportive care, does Voretigene offer one or more of the following other benefits for patients with RPE65-mediated inherited retinal disease? Please select all that apply. Now, Sonia, let me just check. I believe that this voting question will have to be one by one, and so we will not do all that apply as far as the voting.
They're able to select multiple.
Okay. Okay. So when we actually do the vote with the computer, will they be selecting all? We'll have one vote in which they will be selecting all that apply. Okay. Sorry, that was just for my clarification. So we won't be having 6 or 7 separate votes. It'll be one vote in which you will select all that apply. All right. So let me read. These are just the shorthand versions. So I'm going to read all of them, and then we'll get a chance to focus on those in particular that you think do offer other benefits, the ones that reflect other benefits, I should say. So A is, this intervention provides significant direct patient health benefits that are not adequately captured by the QALY. B is, this intervention offers reduced complexity that will significantly improve patient outcomes. And this is compared to best supportive care, all of these. This intervention, C, this intervention will reduce important health disparities across racial, ethnic, gender, socioeconomic, or regional categories. D is, this intervention will significantly reduce caregiver or broader family burden. E, this intervention offers a novel mechanism of action or approach that will allow successful treatment of many patients who have failed other available treatments. F, this intervention will have a significant impact on improving patients' ability to return to work and/or their overall productivity. G, this intervention will have a significant positive impact outside the family, including on schools and/or communities. H, this intervention will have a significant impact on the infrastructure of care, including effects on screening for affected patients, on the sensitization of clinicians, and/or on the dissemination of understanding about the condition that may change how patients are cared for in many ways that extend beyond the treatment itself. And I, which is not listed here, because it'll be a point of discussion, is whether there are other important benefits or disadvantages that should have an important role in judgments of value of this intervention. So I've got the long list here. You can, again, look at the shorthand up there. I'm sorry, many of you may not have the papers in front of you to be able to read these. I hope, especially for Janet, I read through them, and I know...
I'm fine.
Are you okay? All
Yeah.
right. Why don't I invite you then, actually, if as you heard that list, the question again is, if compared to, the best supportive care, which has been what has been done for patients up till now, which of these other potential benefits do you think are most important in people's consideration of the overall value of this treatment?
After listening to the list, I really am inclined to say that they all have an important placement when we're talking about these various issues that certainly are important in this discussion. So I think that they all play a valuable role, coming from a rehabilitation perspective, but also from a perspective of someone who's lived with retinitis pigmentosa, but also from someone who has been a policy developer, looking at disability programs nationally and looking at issues like productivity, employment, educational issues, community. All of these particular areas that were listed on that list have a significant impact in the roles of the lives that these individuals play in a supportive role when taking the actual question into consideration. So I think that it's important because they all touch on those particular aspects of an individual's life. I think that it's also equally important to emphasize the fact that there are other areas of content that I think that need to also be taken into consideration that were not on the list as well. And while all those are incredibly important, I think also we haven't really talked about the role that some of the other healthcare issues that individuals may be coming to the table with as candidates for this type of a treatment and certainly therapy, in that when there is this type of an intervention or therapy available for individuals, that oftentimes they may be dealing with other medical complications or medical conditions that they may also be dealing with that may be less prevalent but equally important in the roles of their lives. So thinking about issues such as comorbidity issues that will impact medical compliance of some level are really important, because when individuals have the strategies and the techniques and the tools that they need, that they're going to be much more compliant as long as they're educated in that process and have the access to do it. Individuals with low vision or no vision at all oftentimes are required to take medication, whether it's directly for their condition or for another condition, oftentimes have much more difficult time with being able to be medically compliant if they don't have the associated training or access or strategy for being able to access the way that they should be able to take their medications independently. Also, we haven't talked about something as preventative as falls and other kinds of injuries that may occur for individuals, particularly younger individuals. We often associate falls, with the elderly community, but individuals who are losing their vision oftentimes have trouble with being able to navigate certain environments, particularly when the discussion that we had this morning around lighting, individuals who are traveling in subways, being able to have depth perception issues and navigate those and understand how to best be safe in those issues. So with this type of a therapy, I think that it gives the opportunity to not only complement it by the therapy itself, but also to take those other considerations into the forefront of the discussion, especially when complemented with other services and supports that still will need to go on beyond just the therapy itself.
All right, thank you. Caitlin, anything you'd like to add to that?
I don't know if I have too much more to add. I felt like that was a really good summary. I mean, I know a lot from my own personal experience to jump off of the whole falls or accidents. I know as being visually impaired growing up, out of the 3 times I've ever been to the ER in my whole life, one of which was because I walked into a music stand and cut my own cornea. So it's definitely that is an effect of being visually impaired, definitely talking about all of the effects it has on the individual and how that can affect their employment, their education, their school life, their community. It's huge to be able to compare my life before the treatment and after, because when you are at that precipice of losing a ton of vision, losing the functional vision, whether you were already considered legally blind or not, you had something that you were able to work with. But once you would have to readapt and change and relearn your whole way of living, it interrupts your life. And for most individuals with RP65, that happens when you're trying to determine your life around adulthood, college age. And that's what was happening to me while I was trying to go through my own education and degrees. So it definitely allowed me to continue with my education, go on to a master's and be employable. And definitely from the reports and some of my own research, because I haven't had the time to know anything about really the visually impaired or blind community, even if I am one of it. I've been trying to make sure that I've independent, and that has taken so much time and effort that I don't know the statistics, but hearing how few individuals are employed, how few individuals are above the poverty line or that even have a college degree, it's amazing to me, because it's like I had to do all of this to get to where I am. And that took time, that took effort, that took support. And I would be nowhere without those individuals that put in that effort with me.
All right, thank you. Marita, would you mind commenting on how the modeling sought to capture any of these features? Sometimes, part of the reason that we have this is because sometimes the modeling efforts, we don't highlight the modified societal perspective. So since this as an ultra-rare disease treatment had that modified societal analysis kind of twinned, if you will, with the health system perspective, did you want to comment on some of the aspects around trauma or mental health or other issues that might be linked to some of the factors that Caitlin and Janet just mentioned?
Sure. So, trauma and depression costs, as I mentioned, were directly included in both perspectives in the model. So we're trying to capture the costs related to that. And then I guess the ones that would be called out most explicitly are productivity loss, F, and the caregiver one, D. So both of those we included pretty significant costs for in the modified societal perspective. So those two we did feel for this patient population can have a significant impact. So we were pretty inclusive with those costs.
Okay. And just to signal to the CEPAC, even if some of these factors are in the modeling results that you're going to discuss soon as part of overall value, it doesn't mean that you would vote no here just because it's already incorporated. That this will kind of sit separately in the way that it helps inform people about different aspects of value. So any questions or comments from the CEPAC about this list of other benefits or potential additions to it?
Can I make
Based
one
on
short comment about the
Sure,
clinical?
just-
Yeah, I think one thing that's really underestimated from a clinical perspective is just the utility of the quality of life benefit gain from Voretigene versus standard of care. And unless I'm wrong, it looks like the standard of care, the number is 16, and then the Voretigene treatment is 17.3. And I don't know where these numbers exactly are derived, but I think, obviously so visual acuity, visual field, we saw the list of what they were looking at for how to put a number on quality of life gain by having this drug, but they couldn't, but it's new. MLMT, which was the primary outcome measure in this trial, and then the FST, the full field stimulus threshold, of course, weren't part of that equation. And then I think quality of life, I just think, is overall very much underestimated. So my feeling, and I'd like to hear from the patients next to me, is that, I just gut feeling a difference between 16 and 7 if you have nothing done and go blind versus Voretigene, and that number is 17.3. That just seems grossly low to me. And so therefore I would think that, and that just might be inherently because of the difficulty in quantifying quality of life. But from a clinical perspective, I think, and having met a lot of these patients post-treatment, I think the quality of life gain is much higher than that post-treatment.
Actually, I'm going to direct the response or a comment to the modelers, because part of this is just the features of modeling that captures changes over time. And so the marginal difference summed up versus what we say is the impact on quality of life in the short term. Can you guys comment on that?
Sure. So those two numbers that you mentioned are the total quality adjusted life years over the remaining lifetime of the patient. And that's what we see, that 1.3 difference in total quality adjusted life years. That part of that is the difference in quality of life. So, and within that quality of life measurement, part of that is what benefit do we get from Voretigene right at that baseline as soon as you have the treatment, and then how is that maintained over time? And that goes back to the correlation with visual acuity and visual field, which is how we calculated quality of life in this model. So it's a combination of what is the quality of life benefit, and that's not, these patients weren't completely blind to begin with, and they're not going to fully sighted after the treatment. So we're not using, our utility model has values all the way from blind to fully sighted, but that's not the full range of benefit that we're getting in this patient population. So it's that, what's that jump in utility, what's the duration of the treatment effect, and how does that sum over the lifetime of the patient?
So I would also add, if you've seen enough cost effectiveness results, changes of more than one quality life year over that extent of time is actually still a pretty big impact. And sometimes people, though, think analysis only suggests that having better sight is 17/16ths, better or something like that. But actually, the distinction of having perfect health and the kind of visual impairment in this study was a big drop down from 1 to 0.6. And just again, to get a benchmark, what other conditions would have people around a quality of life of 0.6? Anything else you can roughly benchmark to that?
The one that comes to mind is psoriasis was around there, I believe, some of those kind of things, but not, so.
Just to be clear, not mild psoriasis.
No, moderate to severe
right,
psoriasis
right.
is about a 0.6. We can kind of look up the comparators. I don't have the comparator for the 0.6. We have some for some of the other suggested values.
Right.
But it's a significant drop. So 0.4, which is what the top end to the bottom end is a pretty substantial range of quality of life. Now again, that's not the full length of benefit we're modeling because, as Marina mentioned, they don't go from a visually impaired state to perfect health. But we do see a bump, and certainly there's a benefit on the scale.
Okay. Are you folks able to hear in the back? I didn't think so. So you at the front, you're just going to have to pull it close to yourself when you speak.
Sorry.
That's okay. So,
I'm
comments.
a
Brian.
little confused. I'm sorry. Was there someone else that didn't mean to jump in? I'm sorry. I guess I did mean to jump in because I did. So sorry about that. I'm confused. Are you saying the psoriasis change was the same as the visual acuity change?
Not the change, just people with moderate to severe psoriasis, their health state utility, so on a scale of 0 to 1, is around a 0.6 at baseline, basically untreated.
Psoriasis rate.
Paul.
Another reference point from heart disease would be that about 0.6 is comparable to fairly significant heart failure, where people are fairly short of breath in their activities, just trying to get around. So we would consider that to be a pretty uncomfortable, pretty poor health state at 0.6.
Yeah, just
go ahead, Harold. Yes.
Sorry, just quick. If you look, Tammy Tang's produced this well-cited compendium of 1,000 conditions in their quality of life. Very, very few go down to 0.6. I mean, you have pain and depression or really significant functional impairment would get you down there, but it's actually pretty unusual to see. So there's no question that this analysis suggests a major improvement connected to the medication as captured by the quality of life units, at least as I read it.
Okay. Other comments or thoughts about? Oh, I'm sorry, Janet.
I just wanted to add a comment regarding the distinction with regard to the visual fields as well as the acuity for individuals. The functional vision, we talked a little bit this morning, about the functional vision also, but for many individuals with visual impairments, and most people who are blind in our country are not totally blind and have some level of functional vision anyway. But the importance here, I think, with regard to this discussion as well as the therapy itself, is that the improvement, and I'm not sure if that's captured in the actual measurements that were mentioned with regard to functional vision, because individuals who have visual impairments oftentimes can function very differently. Even with a higher acuity, it doesn't necessarily mean that they have great visual function or the ability to function within their respective environments in a way that they are confident to move about, in their environment. And so I think that any improvement in the quality of life is also going to, I think, assist with certainly improving their ability to function and utilize their residual capacity for the visual system that they have, if there's an improvement, should certainly improve both their confidence and their ability to utilize that functional vision that they have remaining left as they're in a program or therapy like this as well.
Great, thanks. Dr. Kay, I did want to invite you to comment on H, which is the potential that we've heard about, at least for some ultra-rare conditions when there hasn't been a treatment, and then there is a treatment, and how it kind of can catalyze a shift in the way that clinicians screen for conditions, diagnose them, how information, in a sense, is shared among the community, and just so these kinds of broader, what we sometimes call infrastructure of care changes. How would you anticipate this treatment potentially changing the way that children and others with this condition and the whole infrastructure of care? What's going to happen?
Sure. I mean, I think this is a very exciting, and actually I'm very honored to be here today because I think that's why I took off a couple of days of clinic and flew from Florida, because this is going to pave the way for how other treatments are done for gene therapies, which are definitely going to be on our horizon. From an ocular and retinal standpoint, there are lots of other retinal gene therapy trials going on right now in phase 1-2 trials, hoping to move into phase 3 trials and potentially other ocular gene therapies down the road that will probably look at a lot of the information from today, and kind of as they embark on the same development of their phase 3 trials and commercialization. From a clinician standpoint, I think that what we really are going to see happen here is, hopefully, one thing I'm working on is increased awareness in the optometry, ophthalmology, retinal communities of diagnosing and educating patients. And absolutely in the patient population, with all of the CNN press releases and the news releases on this, patients are constantly now contacting me, contacting their optometrist, their ophthalmologist, saying, hey, I think I might have an inherited retinal disease. I saw something on CNN about this new gene therapy. Can you tell me? So I think patients are paying attention to this. So there'll be a boom of and hopefully increased patient identification, increased patient screening, and then I think there'll be a need for increased awareness in the ophthalmologic community on how to screen these patients, how to get them to the correct centers for diagnostic testing. Genetic testing is a big part of this, and a push towards identifying these therapies, ideally at a younger and younger age. Did I answer the question there?
Yes, that was fine. Rachel? Yeah.
Just to follow up on that, one question I had is about the impact of screening, which, as you said, increased screening will be definitely a part of the change to the infrastructure of care. But as we heard from the manufacturer, they've been offering this test for free because insurers weren't covering it, in part because existing standard of care was supportive care. So now that has changed, it's possible that we might have an increased burden of costs from screening, and that might be quite broad. Dr. Zimmerman, that was not reflected in the modeling analysis. Is that right?
Correct.
Okay.
I mean, I think it depends on the funding sources of the genetic testing. So yes, the Spark ID, your IRD, would be free for patients and covered by the, at least I was covered, I believe, by Spark for genetic testing for LCA-RP and I believe choroideremia genetics, but that's not for every retinal dystrophy gene. I mean, yeah, I think that the cost of genetic testing, there are a lot of options. There are actually a lot of grant-funded and Foundation Fighting Blindness has options where they completely cover the cost of testing and counseling. So a lot of it is sort of networking and knowing how to get your patient tested. I am one of the sites with Foundation Fighting Blindness where I can actually have patients tested for free from FFB funding, and I'm allowed to say that's what I do at my site. I'm one of the sites. So there are organizations that actually are very much, nonprofits and organizations that allow free genetic testing. I think as time goes on, hopefully insurance companies will be more aware of this, but a lot of insurance companies aren't covering costs completely of genetic testing for patients, depending on the diagnosis. So some patients previously have been left with out-of-pocket charges for our genetic testing, but hence I think the big boom of this nonprofit and things like ID or IRD to allow for funded ways of having genetic testing done. And genetic testing honestly is not that expensive. Every year the cost of the sequencing go down, so we get better and better. If you just wanted to screen the RP65 gene itself and wanted to do screening specifically, now that we know that this is the one gene therapy we have approved, that would be not very expensive. It's just that we do these big panels of 181 retinal dystrophy genes that can be a couple $1,000s if you commercially pay for it. But you would not need to do that if you wanted to just rule out, the FDA-approved therapy option. So ruling out one gene, to sequence one gene is actually very inexpensive.
All right, great. Okay, does anybody have I'm curious also about questions where you're waffling about a yes or no vote on any of these, and then we're going to want to move forward pretty expeditiously to the contextual consideration so that we have a lot of time to talk about the overall value vote. Reem?
I think the one question on this list that I'm really struggling with is the reduced important health disparities. Given the cost of this offered treatment and giving the contextual but the special considerations for visually impaired populations, and given what I just heard from Dr. Kay about needing to be connected to know how to go through the system to actually even be tested and know the options, and listening to all that, and to me this almost increases health disparity, or have the potential to increase health disparities. And I would like to just hear from our patients not only about your own personal experience, because you clearly have managed your way and had the support, but knowing from the communities around you, what are the issues of disparities that you envision, if any, that having this treatment may impose?
Do you want to go first, Kate?
Well, I'm trying to personally understand. So, the question is more about, because the testing is going to be hard to, right now, at least in the given environment, we've all had to navigate it to get screened, to get tested, for me to get in a clinical trial. But now there is a treatment. You're wondering if it's going to be still just as hard for a person to get to that treatment? Does that change the disparities between the patient population for those who can navigate it versus those who cannot?
Right. Is there any differential, different between some people being able to do that and some not? Even if they're tested, some people being able to get the treatment and some not. So this differentiation between different patients or people with visual impairment with this condition.
Well, my thinking, at least from my experience, is that yes, it did take a lot of effort on my parents' behalf to get me here. And part of that is because of the lack of education for not the parents, but for the ophthalmologist that you go to. It's going to need to be an educational experience for those to know, for others and providers to know about this. That what is Dr. Kay is mentioning is because I've been to many, many doctors through my growing up, and the gene testing didn't exist until I was older. I didn't get tested until I was 10, and I got my genetic results in 2003. So I went years with vision loss, and then even after getting tested, it's not that it even comes up in a clinical visit. So it's an intervention that would have to occur for it to be accessible, because everyone goes to an eye doctor. If you have a low vision or go to a low vision clinic, I would assume that it needs to now just become common practice to wonder if you have had this test before, or just even ask. And I mean, that's at least my experience of it, because it doesn't, my current going to doctors, that doesn't happen. And so, but definitely knowing that there is a treatment out there, and you have to get someone diagnosed, because they don't know if that treatment is for them or not. So that's...
And I think that's important also. I mean, obviously the education piece is really critical, but having this information, for example, the press releases, the media coverage on this particular therapy now has certainly helped. I can tell you that I've heard from people, certainly in my professional career path, traveling all over the country, people are aware of it. I think that we also have to think about it not just from the patient perspective, but also, and not just even from the eye care community, but also from the primary care community, because many of these individuals, we all see our medical doctors, and our medical doctors, usually we're the ones that are educating them, about our conditions and what it is, and how we live with it, and whether or not there's some type of a networking system. So I think that the education piece is critical, but I think that will come. The blindness community, first of all, is a very small community in terms of what we're talking about here today. So families who are receiving rehabilitation services, for example, from agencies and organizations across the country, that information is getting across to those folks. So getting that information out there, but also the potential, as you mentioned, for folks who may not get the information is also really, really important. When you think about, we haven't really discussed much about, the cultural considerations in terms of intervention like this. It's really important to make sure that education process happens in a way that culturally diverse communities can not only understand it, but can have that opportunity to understand ways that it will benefit them, and building that trust and that rapport within those culturally diverse communities to be able to work with providers in the medical systems across our country to be able to feel that intervention is good for them, or that they may be a potential, candidate for that. So I think that the awareness and the education piece is highly valuable, but I think that is absolutely going on, and having that broad release to the media certainly is helping. Social media, using social media to continue to get information out to families as well is really important, but also there are organizations where individuals meet, as well as have professionals come in, to talk about these types of strategies, and certainly new medical information are equally important, which Fighting Blindness does as well. So having those networks available are really going to be important and very valuable.
Thank you. I think there were some really valuable ideas in there that we'll want to capture as part of the summary of the discussion, and may link to some of the policy recommendations. All right, I think we should go ahead and vote on these. So at this point, again, please check all of these for which you believe that compared to best supportive care, treatment with Voretigene offers these potential other benefits.
Twice. I logged out. Well, I logged out and I had to log back in.
Okay. Anybody having difficulty with voting? Sorry, anybody having trouble with voting? Okay. Eric, did you get back in to vote?
Back in, yeah.
Okay.
Yeah.
I can find yours.
All right. So let me go ahead and show the results. I hope it's in a legible format. Oh, good. Okay. From the top down, with a denominator of 12, significant. No, I guess it's going to have to be a denominator of 13 because someone had to.
Me.
Do we know, Sonia, whether the votes were counted twice for the for someone who went in twice? Because it's showing 13 as the denominator.
There might be 3 that count.
I'm from Chicago, maybe that explains.
It's the Chicago people.
D and F will have an extra 1.
Okay, so I'm going to do some ballot destruction here. B, D, E, and F.
No, B, D, and F.
B, D, and F. We need to subtract 1. Okay, so A, significant direct patient benefits not adequately captured by the QALY, 6 out of 12. B, reduced complexity, 1. C would be the reduced important health disparities, 2. This is tough. D, significantly reduced caregiver family burden. That should be 12 out of 12. Novel mechanism of action or approach, 11 out of 12. Significant impact on improving return to work and overall productivity, 12 out of 12. Significant positive impact outside the family, 7 out of 12. And significant impact on the entire infrastructure of care, 5 out of 12. All right. Thank you. We will note the comments that emerged and the votes as well. Let's move on to the contextual considerations. So I'll just read these again. So it's, again, compared to usual care. Are any of the following contextual considerations important in assessing Voretigene's long-term value for money in patients with RPE65-mediated inherited retinal disease? Please select all that apply. A, care of individuals. Let me just read this. This intervention is intended for the care of individuals with a condition of particularly high severity in terms of its impact on length of life and/or quality of life. B, this intervention is intended for the care of individuals with a condition that represents a particularly high lifetime burden of illness. C, this intervention is the first to offer any improvement for patients with this condition. D, compared to supportive care, there is significant uncertainty about the long-term risk of serious side effects of this intervention. E, there is significant uncertainty about the magnitude and durability of the long-term benefits of this intervention. And again, we have open possibilities to suggest additional contextual considerations that should have a particularly important role in judgments of the value of this intervention. So counsel, again, we've had a lot of the discussion both about the clinical context and about the other benefits that may relate quite directly in some ways to these contextual issues. So you may not feel like you have much more to ask about, or you may. So let me just open the table for you guys if you have any questions, or if you yourself have a strong feeling about these contextual issues and how it applies in this particular situation. I'd invite you to make that comment. Rachel?
So I am finding the framing of some of these challenging, thinking about previous cases we've seen and how they've mapped to some of these factors. So when we've looked at things like compared to the standard of care in this case is supportive, but in other cases it has been a well-known treatment which has been shown safety and efficacy over a number of years. So we may have significant uncertainty about the magnitude or durability of this intervention, but it's in a positive direction, or at least we hope it's in a positive direction, whereas in some of the other cases it comes out differently. So I'm finding this to be just a tough question to answer in this case.
Part of this is in reaction to any cost-effectiveness modeling exercise, there's going to be uncertainty. And I guess part of this is you always have to make assumptions that are built into a cost-effectiveness model, and you can always vary those, as has been done, to do different kinds of analyses. But overall, whether you think people reading this report and interpreting policy recommendations, whether, in a sense, the context suggests significant uncertainty about the longer-term risks and benefits for this intervention is kind of the goal.
Right.
Yes, Aaron.
So I'm just still a little unclear because I feel like that so much of the analysis accounted for all of these things. And so much of the discussion has already accounted for all of these things. So I'm unclear on this question. Are we saying, even given all of the attention paid to all of these issues already, we still feel the need to point them out? Or
this is partly also for people who won't read, how many pages is it? 85? More than that, right? It's partly to capture, almost if you will, a signal that they should pay attention to all those different kind of perspectives on the uncertainty.
Even if we feel like they've already been accounted for.
If you feel like they've already been, right, within the report, if you feel like they've been looked at adequately, it doesn't mean that this isn't well, you could almost reverse this and say, we felt that the levels of uncertainty were important enough to create a lot of need to do different sensitivity analyses. So that's one way of thinking about it. But this is not a judgment of whether there's additional uncertainty that somehow wasn't evaluated somewhere in the report. It's more just stepping back. Is this a clinical/treatment situation where there are significant questions about long-term, the durability of the effects we see in the short term and/or long-term risks that are particularly important in judgments of value? I'm still not drawing any easy, bright lines for you, but
No, because these almost seem like just statements of fact. I mean, yes, of course,
No,
this is
they're not.
the care of individuals with a condition of high severity. Yes,
Check, right.
it is. First off, for an improvement, it is. It's like, so it's, I'm just sort of, I don't understand like what we're voting on.
it's sometimes to restate the obvious. It may seem obvious, but it's worth sometimes factoring that in to make sure that we capture it in the votes.
Okay.
Paul?
Yeah, the way I'm interpreting it, I think C stands out separately for me. I think the others could be put into the modeling, and if I agreed with the modeling, I could accept their number. But then I have to look at that this is the first thing ever, and should I change my threshold for what's an acceptable value because this is the first thing available? So I don't know how you put that into traditional modeling.
That's interesting.
That's
because,
how I do it.
Yeah, and I appreciate that comment because I feel like the model accounts for the first off for any improvement because the comparator is do nothing. But I mean, that's the way I think about it. It's just kind of.
Well, I tend to agree with you, although I have heard from others that there's something about being the first thing that makes it different from being the second, third, or fourth, even though they all offer the same benefit.
Yeah. No, I think it's very good. I was going to offer. I'm sorry. If you don't mind. So I know that I can provide it in writing to add to E, F, which is the one that says other things.
Uh-huh.
And I think this has to do with an issue that is a year of life for a 12-year-old different than a year of life for a 45-year-old. And I think in this particular case, we've heard wonderful testimony from Caitlin and Janet and Christine and others today that would say that we have, in this particular case, we influence the developmental trajectory of a human that maybe we're not quite capturing in the calculus so far. And I don't know how to articulate that, so I'll have to think about that in terms of how I might want that captured in the report, but I was curious if other panelists think about that particular issue in this particular case because of when the intervention is provided and the trajectory of life that is impacted because of the educational impact, the socialization impact we know it's not to say that it's not valuable in a 40-year-old. I'm not trying to say that, but it's so profoundly important for a child and the trajectory of their life.
I would agree with that, and I think that if you take a 12-year-old and you take a 40-year-old and you take this scenario, that if you have the opportunity and the means, to impact and sort of course correct preemptively, that you change the course or the direction, the decision making of the person as they mature and as they are preparing to go out into the community. And so that has a significant potential to reduce the barriers that a 40-year-old who has experienced those similar types of challenges or barriers or lack of opportunity. I think that opportunity really is an important word here because it is having that opportunity. It's the ability to make a decision or have your family make a decision based on something that's there, that's tangible now, that has the opportunity to really change the course of the future of that person.
And one comment I just wanted to make to the panel, specifically on E on this list, the idea of the durability. I think it's just such a key concept that we keep returning to, and it's very difficult to come up with a final answer on what do we think the durability is of this treatment. But I think it's so key because if you look at the models, you have radically different numbers in this cost-effectiveness ratio depending on what we're assuming here. And yes, it's an assumption, but if you look at, if you're page 45, if you're assuming the 10-year decline, and you're assuming the U.S. healthcare perspective, the number there is 643,000 versus page 50, if you assume the life-term benefit, and then you assume what I think is the better perspective is the modified societal. I think we're all kind of talking today more like on the lines of the modified societal, making more sense in this disease. The number is suddenly 16,000. So, I mean, these models are widely variable. I think it's hard as me reading this, and I'm not the insurance payer companies reading this to make any decisions, but for me reading this, I would have a really hard time knowing what conclusion to draw from that given the widely variable numbers of 643,000 versus 16,000 of is this cost effective or not. But what I think there is the key, the reason that's important is because, do we think it's durable or not? And I think the answer to that question myself is that we have 3-year data that shows stability. I would disagree that the Goldman visual field declines. If you look at that ARVO poster 2017, it's within the error bars at the 3rd year. So both the Goldman visual field, the FST, and the MLMT were stone cold stable out to 3 years. So that's the data that we've got. We don't have 4, 5, 6, 7 year 8 data. The FDA, we didn't wait that long because we want to get this therapy out there. But for the data that we have, it's stable. I think if you look at the executive report summary, the reason the question of durability came up was because of the Jacobson paper, but again, a totally different vector without the Kozak sequence in the AAV vector without a surfactant, and then the Bainbridge paper, they had an RP65 promoter, so totally different vectors. And so,
but isn't it? I'm sorry. Isn't it fair to just say there's uncertainty because there is uncertainty?
Right. I agree.
But I think you're also trying to argue this idea that we've seen some durability of benefit, regardless of the nuance of which visual field measure we use. Like, let's not split hairs over that. But we really only have data for a certain period of time. And that's it. Like, we have anecdotal stories. And I think the challenge this panel faces, or at least I feel like I have, which is we're asked to evaluate actual evidence, right, that actually exists. And that's okay. I don't think there's anything wrong with that. It's just I think we have to acknowledge that, like, we don't actually know what will happen 10 years out, and to make the assumption with a high level of certainty that there's durability is we just have to recognize, like, it's an assumption. That's kind of I don't know how the other panelists feel about that.
Yeah, I think it's an assumption both ways. It's definitely an assumption, and to do the 10-year decline model, I think, is a big assumption, sort of a pessimistic. In my thought, as someone who's worked a lot with AAV, the idea of long-term expression is what the going field of gene therapy really is long-term expression. So I would say it's hopefully more likely that it will be long-term treatment if we had to err on the side of a model to have our final conclusion. It's just the whole idea of which we chose as the base model here.
Yeah, I think that's fair.
And I think I would have chosen the base model as the lifelong assumption model. And I also think that nonlinear equation is extremely important. If you look at that nonlinear, the numbers on that are radically different too. So for the 3-year-old, it's 161 and 75, and for the 15-year-old, it's 158 and 118. So therefore, it doesn't make much difference at all if you treat a 3-year-old versus a 15-year-old, and they're both really good as far as that number of 150 for cost effectiveness. And I think all that changed there was that nonlinear utility of the vision decline between hand motion and no light perception. So just that tiny, maybe it's not a tiny change, but a little change in how you look at complete loss of vision to no light perception made a radical change on the cost effectiveness ratio. So that's just my 2 cents. I just think that the cost effectiveness ratio is probably the best model is that one with that nonlinear, which we haven't really even talked about. It's on page
Let me just
52.
invite some response, and then we'll have to move pretty rapidly through to make sure we have enough time to talk about the overall value. Marita or Josh, and then David, you might want to pitch in too, but this issue again about, I guess, go ahead, David, you were first. Go ahead.
I just wanted to comment on the 10-year decline because I think this is a confusing aspect of the model. The model assumes, based on the data we have now of 3 years, that with Voretigene, you hold rock steady at the benefit you got for 10 years. And that you continue to get benefit that wanes, not you start declining. You still look better than somebody who never got Voretigene for another 10 years. So you have 20 years where you're doing better than somebody who never got Voretigene based on 3 years of data. At the end of those 20 years, your decline now looks the same as somebody who never got Voretigene. It's not that you fall down to the level of somebody who never got Voretigene. Your rate of decline 20 years out now looks like the rate of decline in somebody who never got Voretigene. So we're assuming a lot of benefit on 3 years of data. Mm-hmm. It feels wrong to me to describe this as a 10-year decline model. It's a 10-year rock-steady model with another 10 years of benefit model.
Josh or Marita, did you want to?
Yeah, so the nonlinear model, the problem with that data was that the base was basically equivalent to a person who just had a major stroke right after they had their major stroke. And in our model, that would be somebody who had a major stroke that would be in that state for 40 years. So it just lacked face validity for that bottom end of the scale. So it was basically putting the bottom end at a 0.25. And so that was just, it was the data that we had that showed that nonlinear part was just didn't pass muster in terms of face validity. Now, there may be a decline at the end. What that number is, we didn't have data to inform that jump. But the data that we did have that was suggested in comments just didn't have face validity because, again, that would be people living in a condition of just having a major stroke for the rest of their lives, which would be, in our model, is, these are 20 years old, that kind of thing. So this would be 40, 50 years in that state. And so that's why we did not use that as our base case.
All right. I'm going to lose my face validity if I don't keep things moving along a little bit faster. So we're going to vote on the contextual considerations, and then we'll have a discussion about the voting on overall value. I'm now going to try to target the beginning of the policy roundtable for approximately 2:20 p.m., just in case people are looking. But we'll definitely get that in for a full hour. All right, so please go ahead and vote on any or all of these that apply. Just waiting for two more folks.
Yeah, part of the problem is you can't not enter.
Pardon?
I don't want to enter anything.
You can do uncertain if that's.
There's no such thing.
Oh, not on this one? Oh, sorry, I thought we had that.
Do yes or no.
All right, there should be like an option that says above.
Okay, I think we're close. All right, so we've got results. Yes, Claudia.
Just a quick question on E. We're meaning compared to supportive care, right?
Correct.
Not a comparator.
Correct. Okay, I believe we've had everybody's answers entered, so I'll go ahead and show the results. All right, so high severity, 9 out of 12. High lifetime burden, 10 out of 12, sorry. First offer any improvement, 11 out of 12. Compared, or actually I'm wondering if so we had 12 responses. So compared to the comparator significant uncertainty about long-term risks, 7 out of 12. And magnitude and durability of the benefits, 11 out of 12. All right. So let's move to the easy question. Given the available evidence on the comparative clinical effectiveness and incremental cost effectiveness, and considering the other benefits and contextual considerations, what is the long-term value for money of Voretigene compared with supportive care for patients with RPE65-mediated inherited retinal disease? You have three choices: high, intermediate, or low. Who wants to start with a question or a reflection back? I will tell you here again, now that we're talking about the specific cost effectiveness findings, that they and many of the others start on page 14 of your summary table here, if you're looking for some of the specific numbers again. Harold?
Oh, this is
sorry, Justin.
sort of a
Awesome.
gestalt comment that I wanted to make in the prior one. There's so many models in here with sorry, I'm getting some feedback, very different results as we're hearing, and each of us, I think perhaps, at least in part, given where we're coming from and our prior preconception of where we want things to end up, are kind of gravitating toward one versus another. Maybe there's a little bit of informed by, you consulted different groups and they thought this way was not good, or there's some argument about durability. And so the general comment is, how do we collectively make sense of this forest of numbers and different arguments. I think that's the real challenge in front of us. I don't have an answer, but
well, neither do I. So for transparency, though, I'll try to lay out what I think some of the considerations are in terms of how you might weigh some of these. So first off, you have different results for 15, quote-unquote, 15-year-old and 3-year-olds, right?
Yep.
In a sense, that's meant to reflect that the relative benefit does, in a sense, track with where the beginning visual acuity is, or I shouldn't say visual acuity, visual function, perhaps. And the average age of the patients in the trials was 15. That's the evidence that's before us today. If you went out and started to treat people today, maybe for today and the next however many years, maybe the average is going to be around 15 because there are going to be a lot of patients like Caitlin who are going to have their first shot at this treatment and they're in their teens or 20s or 30s or et cetera. Over time, especially if the system of care shifts and we get more early screening and more rapid diagnosis, the age at initial treatment will start to drop. How fast and how far is unknown. Will 3-year-olds ever say or walk in, have some kind of effect that their parents will start to rapidly suspect that there's a visual problem, get them in front of the right kind of ophthalmologist and get them diagnosed by age 4? 4 was the youngest in the studies, but maybe that will, again, where that trend line will go is something we can talk about and maybe ask the clinical expert again, but that's the general thing between the 15 and the 3. The modified societal versus the healthcare system. Pros and cons. The societal one seems to capture many of the things that patients care about and their families care about, and that we, or payers and society, might care about. Ethicists might raise a little yellow flag of caution to say that the second we have a similar treatment for people over the age of 65, a genetic treatment for cancer, we are going to extend the life of people who are on Social Security and drawing benefits and not productive. So if we're going to look at those societal factors, should we start to penalize treatments for patients, successful treatments for patients in their elder years? That's been one of the reasons of the caution around leaping to include indirect benefits in every single assessment that's done. The other is that depending on the society and the health system, different decision makers feel like they have more or less responsibility for those costs outside the healthcare system. So there are pros and cons to both. Experts often say you should look at both perspectives and wrestle with that tension as you're trying to come up with your own judgment. So in our report, you noticed that we emphasized the 15-year-old results. We twinned, if you will, the modified societal perspective with the healthcare system perspective. We didn't in any way try to give a whole lot of precedence to one or the other. And there are many other ways to do sensitivity analyses, but to my mind, those are the biggest factors in the kind of matrix of outcomes that you're seeing, and at least some of the factors that you might be considering in your thinking more about one set of results versus another. But that's almost meant to be more of setting the table for your discussion and further questioning, if you will, of the people at the front table. Got it? Awesome. That help?
Yes.
Little. Brian.
So I'm going to introduce something really kind of soft and squishy, and that has to do with the value term, value for money. I mentioned at lunchtime that the idea of a child or young adult now being able to see a Van Gogh painting or a Rembrandt painting, to be able to climb the mountains and see the hills of New Hampshire where I live, is something that I have trouble putting a value on. And I really am struggling with how does one value those sorts of sighted events that we may be able to get. And I realize that the treatment doesn't get you back to 20/20. But that's such a huge gain that I'm not sure how to put a price on that.
Well, health economists, and I will maybe shut up in a second, maybe not. Health economists would say we get at that by asking people sometimes who have sight, what would you give up not to lose your sight? People who have experienced all of those benefits of sight, if you will, how much are you willing to give up in terms of your length of life to maintain that? So they try to ask questions in different ways. Now that's a different answer than you'd get if you asked a patient who was losing their sight or about to lose their sight perhaps. But there are ways to basically ask people to trade off things in order to maintain that kind of almost what seems intangible benefit, if you will, or wonder of life. So it's nothing that special about vision in a sense of how you might go about asking about what it's worth. Not that it's perfect, but that's kind of one approach. Anything else the true health economists would like to add to that, or others?
No, that's pretty good. I mean, you value those things, right? But you ask just as many people and to ask what they would trade off for the things that they value and how that treatment might help them trade those things off. So.
And yeah, that's what our utility values in the model are based on, is that data.
Let me ask, while we're pondering some of these deeper issues, we've touched on it several times, but we have one clinical expert in front of us. This age at treatment, where it's going to start at, where it's going to end up, how fast it will shift. Again, what we know is the average age of the patients in the trials, and we know the youngest. What would your perspective be on how rapidly the average age would start to drop, and where would, like 5 to 10 years from now, what is the average age at the initiation of treatment likely to be, given what you think is going to occur? And it's not going to be perfect all around the country, et cetera, but if you had to guess, what do you think the average age at treatment will be in about 5 years?
I think that's a great question. I would say for the first 10 years or so, 5 or 10 years, it'll be all the patients that are living in the U.S. right now that are identified, whatever age they are. Yeah. But post that, it just depends on what age. I mean, the big question is, what age can you identify these children? I was talking to a few people about that, and it is a highly misdiagnosed disease. And we also always forget the phenotype of the RP20. So not everybody is LCA with RP65 mutations. There is a retinitis pigmentosa mutation. In fact, the oldest patient in the SPARK trial was a 44-year-old. She was diagnosed in her 30s. No idea that she had, she actually had normal vision as a child. So she had the retinitis pigmentosa version of this, the phenotype, where she had normal vision and then slowly, progressively had vision loss. So, I mean, we're always going to have older individuals. If you looked at that original graph with the percent that's LCA, that was in the 40% range. So somewhere, 50 to 60% are other phenotypes that have later onset. So that is one factor. But I mean, ideally, the sooner we can genetically test people, the better. You could also even toy around. I don't want to even bring it up, but the idea of, can you do screening on it? Now that we have an FDA approved, I'm sure that people have thought about this. Can you just do neonatal screening, screening on this one gene and see who has this, so we can identify everyone prior to even symptom onset? That may or may not be a good thing for the society, or for ethics in general, but that's just a question, because you could theoretically diagnose people at birth prior to symptoms if you genetically tested for it. It's a genetic disease. But I would say the average age, just to be really straight, of my typical diagnosis of LCA, and this is the one that's theoretically infantile onset, is still somewhere between the ages of 6 and 10 because of misdiagnosis rate is so high. And these patients are popping around. I had a patient who was misdiagnosed with autism, so he bounced around between neuropsychologists, and they really didn't have any, they noticed his eyes were shaking a bit, but he had behavioral and social issues, which these patients, a lot of them have, due to their poor vision. So he bounced through their completely wrong venues for the first 5 years of his life, then finally had this first electroretinogram. Those often require anesthesia, so we're sometimes waiting until a patient is 5 or 6 so they don't have to go under anesthesia for the ERG.
So the LCA 6 to 10, and then the other about 50% of patients will usually get picked up later
probably
because of
in their
symptoms.
Adolescence or 20s when they start to have symptoms for RP.
Okay. So we heard this, I know the team heard this as it went through its months of deliberation, and that's one of the reasons that the 15-year-old, both because it was the study and because of the diversity of the patient population, that it ended up being the one that we gave more emphasis to in the reports. Sorry, Josh, yes?
Yeah, I was just going to, for Austin, I think a way to kind of work through the results would be to think about what perspective you want to focus on. Start there, make a choice, then move on to thinking about the durability effect, do you want to go with the 10, 10 to the 20-year, which is the base case, or do you want to go with the lifetime? And that'll begin to get centered. And then you can think about the third one, which is the age effect. So do you want to think about patients right now, which are probably going to be representative for a little while of the trial results, or do you want to think about sort of more of a future steady state, which it may come down a little bit? And then that'll kind of work your way down to the results you might want to focus on.
Well, there's also the nonlinear, which we've heard about.
Sure.
But some people really strongly gravitate toward it, and maybe.
Yeah.
But you are sounding like the team is de-emphasizing it because of qualitative robustness checks kind of that you did, or feedback that you got.
But yeah, absolutely. And then you can take that into, that could be the fourth one that you want to go to. Sure.
All right, yes, Ed, and then I may ask a couple more questions of you all before we vote.
I'm not sure how much I should be concerned with the potential for scope creep. Obviously, these patients were selected for likely receiving a lot of benefit. In the real world, we tend to see scope creep where not necessarily the most ideal patients are selected for treatment. And I don't know if the diagnosis using genetics means I shouldn't worry about that. So let me just ask, is there a potential for scope creep? And should we expect that the cost-benefit ratios will get worse in the real world?
Can you explain one more time what you mean by scope creep? Because I didn't quite.
We know who's likely to benefit, but oftentimes when a clinical intervention is available in the real world, clinicians don't always stick with the ideal population. This was tested in an ideal population. Does the genetic testing make us sure that there won't be non-ideal candidates?
Well, right now, the FDA approval indication has left it up to the treating physician looking carefully at the patient. It has to be an inherited retinal disease doctor looking at this patient, looking at their scan. So they're going to have gone through testing, OCTs, look at the structure of the macula, look at the patient, all of the testing that we have, and see if they think that there's viable retina to treat and the patient is a good candidate. So I think that's an important thing, is that it's not just going to be everybody. You're not going to be treating a 90-year-old who has no light perception vision, in this. I think we have to leave it up to those treating retinal physicians who are going to be experts because of the centers of excellence. Those are going to be IRD experts who do this for a living, is look at retinas. They're also, we're good people too on the clinical surgical side. We don't want to put a patient through a treatment that we don't think is going to be helpful and effective for them. So we're going to be looking at these retinas and these patients, talking to them, informed consent process. There'll be some patients who don't want to do it, don't want a surgery. And then there'll be physicians who say, I don't think your retina is going to benefit from this. So I think we're going to have to leave it up to that. I'm optimistic that, we're going to be able, as a retinal community, to be able to identify those patients. And I think it'd be a similar population as the trial, because I don't think we're going to be selecting patients that have non-viable retinas that are elderly with no light perception vision.
I'm going to come back to that question in the policy roundtable as well, however. All right, I need to move through. I want to have you guys hear each other's thoughts. Could I invite someone who's going to vote high on this to give a short description of their reasoning that leads them to a high value vote on this, if there is anybody? May I invite anyone who's going to vote intermediate? Okay, I'm sorry, high or intermediate?
Yeah, I vote for high.
Can you please describe your thinking briefly?
Just consider start young and have a lifelong effect. And also, this is the first new genetic treatment. And we wanted to see, is it a field of great potential? And so that's the reason I voted high. Kind of optimistic view of the whole treatment.
Does anybody else want to complement that with another thought about their vote about high value before we move to intermediate? Brian.
Yeah, I'm basically going to just say the same thing, that I think that this is a breakthrough therapy that's got high utility and great benefit for the patients.
Okay, intermediate value. Anybody who's going to vote intermediate want to describe their thinking?
Sure.
Okay.
I don't disagree. I think that there is significant benefit, but given the questions about what's going to happen in the long term plus the cost, I don't know that I would say high. I'd say probably intermediate.
Okay. Yeah, I know. Make sure that you pull that mic directly at you when you talk. That's okay. You might just briefly respond.
Say it again? Sure.
Yeah.
I don't dispute the significant benefits, but given some of the uncertainty about how long that they will last, and given the cost, I didn't necessarily think that this would fall into the high category, that it was probably more intermediate.
Okay. Any other intermediates, Austin?
Well, I'm not committing to an intermediate vote at the moment.
I know you're not. No, the point here is not to commit. It's to listen to each other's thinking.
I'm torn, but the reason I would go to intermediate over low is precisely because it's the only therapy for this population, and it's a novel approach that it's kind of a breakthrough. That would kick me from low to intermediate, but I haven't decided whether those are enough to put me over the line.
Okay. Since you asked the earlier question, when you weigh the variety of cost-effectiveness results, which one is percolating to the top?
This wasn't too hard for me. I focused on the 15-year just because I think we should look in over the nearer term versus longer term, because so much is going to change in the long term with technology. This may be we maybe have 5 therapies for this population in 10 years. I don't know. We may have something that works much better. So I was, and so the 15-year-olds, then I was discounting the nonlinear for reasons raised. I think not necessarily going with the lifetime benefit, because I think that's very uncertain. And after that, it's there's the society versus healthcare, but I think that narrows it down enough that I can kind of lock in on for the purposes of this.
Okay. Anybody who's anticipating that they may vote low value want to say why? Paul?
Yeah, I'm not sure yet how I'll vote, but one thing this is very compelling for this group. I think about, at this price and a limited healthcare budget, what am I not going to provide to people? So what other conditions might I be able to help them? And I'm saying, nope, that money, for whatever that is, I'm taking away and giving to this group. And so I have to keep that in the back of my mind as we consider this. It's not, I think we do have a limited healthcare budget.
However, the number of patients this is an extremely rare disease, so I guess we're going to get into the policy in a minute. If you look at the impact on the total budget, it's a tiny amount on the total budget. There are probably about 1,000 people in the U.S. that will be treating, so this is not an age-related mac degeneration population, and it's a one-time therapy. So I think overall that it's actually a very low number of the overall budget. I don't think any other diseases are going to hurt from this.
All right, and we are verging on getting to the policy roundtable, where we'll definitely talk about some of these other issues. Yes, Caitlin.
So I just wanted to add, before you all were able to cast your votes, I understand you're choosing its value, and I'm sure a lot of it has to do, with the economic value, because that's a majority of why we're here. But and we're talking about the 10-year possible, stagnant and a decline, or the model that has to do with the nonlinear model. And a few things I have to say are, one, I know that there's uncertainty, but the one thing that is certain is we are going to go blind otherwise. And second, the nonlinear model, I can't tell you the economics behind it, but I can tell you, as an individual who's at that brink of going from having some functional vision to none, that's when it matters the most. That's when it actually is so valuable to an individual. Because there are years when you're younger and you are losing vision, but you're still functioning. It's the part at which you're going to stop being able to function with your vision, and you're going to have to rearrange your entire life, that it is extremely valuable. And so I just want to bring up those two facts that have nothing to do with the economics, but with the value of it, and that otherwise you're going blind. And as a person reading through this report and who's had the treatment, and to be under this estimation of this is only going to last you 10 years, it's hard to read, because I'd rather go with it's uncertain than putting a cap on it, because then I'm back to where I was before the treatment. And I understand it has to be done for the economic models, but that wasn't the point of the treatment. The point of the treatment is to retain the vision. And if down the line you find out it doesn't, then that's a new fact. But we don't know that yet. So.
And I would just add to that also that if you're thinking about it from an economic perspective also, to take into consideration not only the quality of life issues that we talked about today, but also the support systems in the family systems that are charged with taking care of and supporting individuals who are losing their vision, but to also think about it from an economic perspective in terms of productivity, but also as well as from a return on investment. And so when individuals have an opportunity to receive a treatment like this, you're also providing the opportunity for that person to go on with their life for whatever period of time that it is, which gives individuals that time that they need to be able to, number one, benefit from the treatment, but also to think about it from the perspective of if these individuals are getting their education, if they're able to engage in work, to increase their independence, the return on investment for that, we can calculate that, and that is calculated oftentimes in a rehabilitation, from a rehabilitation perspective, but also very tangible dollars in resources to our country. So these individuals, for every dollar that is spent on an individual in a rehabilitation program that's blind, $7 is returned to the state, to government programs, so that these individuals are now becoming taxpayers, and they're contributing, and they're not draining on the actual system. So it's not just an economic perspective in terms of the weight or the burden on the companies, but it's also on the other side of that scale is the return on investment and the positioning of these individuals to become productive individuals, whether the treatment is 10 years. If I got offered this today and you said to me today, take this treatment, we'll give you 10 years. This will give you 10 years. It'll give you 20 years maximum. I would say I'll take it. I will go for it. There might be others who might not go for it, because I'm thinking of it from the perspective that it gives me that opportunity to slow the progression of the condition, to work with it. It's not a cure, and I don't think that anyone is saying that it's an actual cure, but it gives you that opportunity, to take that remaining portion of time that we have to be able to effectively work with this treatment as we're receiving it and going on and making other important life decisions about our future, to be able to benefit from that type of a treatment and therapy, which ultimately gets returned back to our government, back to our country, back to our states, whomever, back to our families and to ourselves, most importantly.
All right, thank you. Thank you very much. All right, CEPAC, let's go ahead and finish the voting. This is the long-term value for money of Voretigene compared with supportive care. All right. 2 high, 7 intermediate, and 3 low. Thank you very, very much for the rich discussion that we've had as part of the voting process all the way through. Because of our time, we're going to make a rapid transition to the policy roundtable.